He said he will be joining in 5 minutes. I called him up.
I was having that meeting of this pneumonia module.
Dr. Subramania, sir. So as you know, like previous time,
Yeah,
after Clarnet's video, should I hand over the session to you or to Dr. Pawan Kalyan?
yeah, fine, done, point taken. Okay.
No, she's asking whether to hand over to you or to me.
No, please hand over to me. I will hand it over to Pawan. And
Okay.
Pawan will introduce the guest.
Okay, sir.
Yeah. And see that he will join. He's joining live means you just see that all those technical issues are sorted.
Okay, so I have also made you co-host, two of you. So you can do anything I can do. So if there is anything
Yeah,
from my
I
end.
saw that. I saw that.
Okay,
Yeah.
sir.
Now, greetings and welcome from Indian Academy of Pediatrics National Respiratory Chapter. Myself, I'm Dr. Subramania. I'm having with me Professor Dr. Jagdish Chinnappa, who is the president of the chapter. From both of us, warm greetings and welcome. And it is nice to see that all of you, in spite of the webinar fatigues that have happened in COVID times, are still interested and enthusiastic to learn. And that's the spirit which drives us to arrange and organize webinar series which we call from our pulmonology as respinars. So this is ninth such one, and we are going to have at least full century, 100 of them with all your blessings. So that's some kind of or should I say dream for us. What is also heartening to see is that we have with us today uh, Professor Dr. Hemant Savnani. He is born, brought up in India, studied in Mumbai at the prestigious KM Hospital, or I would say GSET in GS Medical College, and then went abroad, and now he has completely established himself and got recognized and is serving pediatric pulmonology in his area of interest, sleep, and also in neuromuscular problems in children. So that is his area of specialization. He was talking to some of you a while ago, and many of you must have been already informally introduced to him. Now, today's session is because of relentless efforts from our own pulmonologist, younger brother of mine, executive committee member of Indian Academy of Pediatrics Respiratory Chapter, Dr. Pawan Kalyan. He is also doing wonderful work in India, sir, Dr. Hemanji. So he's a very good pulmonologist who got trained abroad, and then now he's back to us, to Mother India. So so with these words, I will request every one of you, please join our respiratory chapter, join all the respinars, feel free to interact. I would also request Dr. Hemant Savnani at the end of the day, kindly send us an article of today's topic, if at all you have, so that we'll publish it in our journals or in our periodicals or in our newsletters, and it will reach to those of them who could not join for various reasons today. So it will reach out to everyone. A small draft we would be very glad to have from you. So that would be very nice for us. So with these words, I will request Dr. Jagdish Chanappa to give his opening remarks. Dr. Jagdish.
Thank you, Dr. Subramania, and welcome to all the participants who are in the audience here. I think we have slowly realized the importance of sleep. And yesterday we had a very long, comprehensive program for the pediatrician to sensitize them to sleep issues. And Dr. Pawan was one of the faculty in that meeting. So now I think, as Dr. Hemant was speaking to us a little time back, India is at a nascent period of pulmonology, and we are now just emerging into getting into more and more specialization. And one of the major specialization is sleep and its attendant problems, and non-invasive ventilation, neuromuscular disease and its problems. So I think we are getting one of the best persons in this field to talk to us. Dr. Hemant specializes in this, and it will be a delight to hear his views on how they manage it at Cincinnati, and then we can see how we can progress in India. So welcome, sir. Welcome. Thank you very much for coming here this evening and enlightening us on this particular topic.
Well, at the onset, I would like to thank.
Thank you, Dr. Jagdishanappa. I will request Dr. Pawan Kalyan to moderate the session. Hemant sir, Dr. Pawan will give his opening remarks and he will introduce you, and then you can start your presentation. Over to Dr. Pawan Kalyan. And lastly, we will have questions, sir. Questions will be typed in question and answer box. If you are able to see, it's okay. Otherwise, we will ask all of them at the end.
Sure.
So there should not be anybody who will be disappointed with any unanswered questions. We'll see that every question will be taken up and will be asked you at the end of your presentation. I will hand it over to Dr. Pawan Kalyan to moderate the session. Dr. Pawan Kalyan, please.
Good evening to Dr. Jagdish sir and Dr. NK sir and my colleagues who are in the delegates. It's a pleasure and honor to welcome Dr. Hemant Sanani. It's a dream come true. I was at Cincinnati in the year 2015. Since 2016, I was trying to catch hold of sir to give a talk to the Indian respirologists. We are just at a nascent stage, as Dr. Jagdish Shinappa sir said. And to start reading the introduction of Hemant would take not an hour, it would take a day. So let me give a brief introduction of Dr. Hemant and how lucky and how privileged to have Dr. Hemant to us. He has did his undergraduation from Sage GS Medical College in the year 1990. From there, he pursued his pediatric pulmonary, pediatric pulmonary, and pediatric sleep medicine from USA. He has been the associate professor in the division of pulmonology and sleep medicine in Cincinnati Children's Hospital. It is one of the top 5 hospitals in USA. And he is not only the associate professor, but he is the clinical director of neuromuscular pulmonary division, Cincinnati Children's Hospital at Cincinnati. It's my honor and privilege, if you have seen sir working with when I was at Cincinnati to do my observership, I had a privilege of working with him for neuromuscular, cardiomyopathy, and they have a team. As sir said, there was a couple of, now they have been subspecialized in subspecialty. Now, to his achievements, there are a number of achievements which, if I enlist, are many, but I will tell the very few which are important. He has been awarded as a Dean of School of Medicine Award for an excellence in research and presentation by a resident fellow in the 14th annual Chilean Medicines, and he has also received a travel award certificate. For his clinical service, I would tell you, he has been seeing nearly about 1,000 neuromuscular kids and cardiomyopathy, or you take any spinal problems. He's been looking up after those kids in and around the Cincinnati area, Ohio State. And not only that, for them, they have a long-term tracheostomy or long-term ventilation units, which is a 24-bedded. It is the real complex cases. I have seen there would be a lot of discussion. To handle such cases is very difficult. Those long-term ventilations would be ventilator dependent or tracheostomy. So he monitors those kids also. And to his acknowledgement, there are a number of peer-reviewed publications under his name, and he has been author of many chapters of neuromuscular chapters in various textbooks. Let me be frank enough to say he will make neuromuscular disease in sleep in a very, very simple manner, and everybody will be fascinated. Thank you, Dr. Hemant, for accepting my invitation and giving and sharing your knowledge to our Indian pediatric pulmonologists and the people who are interested in pediatric pulmonology. Mic is yours, sir. Stage is yours, sir.
Thank you very much, Pawan. It's been a pleasure. Thank you so much for the invitation, Dr. Subramaniam and Dr. Chinappa. Pawan came to us, spent a little time in 2015. I think it was maybe about 7 to 10 days after a course in bronchology. He came to learn his flexible bronchoscopies from none other than the father of pediatric bronchology, who is Dr. Wood, who actually just retired this past Friday. He wanted to do the 40th bronchoscopy course, but given the COVID issue, we may have to lay that to rest for now. So he retired a little ahead of schedule. So without much ado, I'm going to go ahead and share my screen. And I'd like for you to be able to tell me if you can Do you see the
Yeah.
PowerPoint?
Yes,
Yes, sir. We can see full screen, no problem.
Okay, excellent. Thank you very much. So I'm going to actually, my agenda today is very simple. I take a very practical approach to what I do and to understand what I do, and also to teach my patients and families about what I do. And it's important that we educate our patients and families so they can see the value in coming to you for follow-ups, the necessity and the importance of follow-ups, and also to be active participants in their own care. So I'm going to, I'm not so sure whether there were all pulmonary or non-pulmonary people as part of the audience. And so I wanted to take a very basic practical approach to explain some simple pulmonary mechanics to non-pulmonologists. And I sometimes take the similar approach when some of my audience is much more neurology or non-pulmonary sleep physicians. I do want to talk a little bit about the spectrum of neuromuscular disease pathology and what really falls under that umbrella, and specifically some polysomnographic findings and the therapeutic approaches we would take to that. So, as it stands, we know that we are structured with 12 pairs of ribs that articulate in the back to a series of vertebral bodies that are lined one on top of each other to form this wonderful multi-jointed articulating structure called the chest wall or the rib cage. And the beauty of this structure is not for the shape that it offers us, but for the function that it really serves, right? So really, we would not be able to breathe effectively the way we do if we didn't have a rib cage. So what does that mean? Well, if you think about it, when you take a normal breath and you have a tidal breath, the diaphragm contracts, gets shorter, and excurs and moves downward. What happens is it creates a negative pressure in the chest, a negative intrapleural pressure, which draws air into the lungs, and that is how we normally breathe. So as a result of that, you experience the pump handle movement of an anterior superior movement of the sternum and anterior chest wall, and also lateral displacement of the chest wall or the rib cage. And these two occur in two different dimensions. One is anterior posterior, the other is lateral. And think about it, there was a vertical increase in thoracic measurements as well with the diaphragm moving down. And that's why you don't even wrinkle your shirt. You breathe in 500 mils of air in a single breath, and the displacement of the chest wall occurs in all three dimensions. So this is one very important concept that I need for you to understand, that we need three-dimensional excursion of the chest wall for normal breathing. Now, when we look at the functional integration of how all of this occurs, it's far more complex than this simplified diagram. So you have a cortex that initiates conscious respiration, particularly during the time where you are angry or you get excited, you breathe deeper. The times that you are not really consciously thinking about your breathing, the impulses are still originating from different parts of the brain, lower areas, not always the frontal area. And that then goes to the brainstem, to the autonomic respiratory centers. Now, what occurs over there is very interesting. There is release of there is integration of the chest wall muscles, and as impulses go down the spinal cord, down to the intercostal muscles, there is involvement of the diaphragm through the phrenic nerve. Okay, and your abdominal muscles, intercostal abdominal muscles also get integrated for, let's say, if you have to take a cough or if you want to take a sigh. But also the other important part is the upper airway muscles. You can hold your hand out in any particular direction, and the reason it's stable is because of constant feedback mechanisms between extensors, flexors, abductors, adductors at the shoulder. The same is true for whether you do that with your elbow or arm. Well, the same is true for the upper airway. So pharyngeal dilators and pharyngeal constrictors all are influenced by basic tonal discharge from the brainstem. The other things that influence respiratory drive are your upper airway receptors, carotid bodies, and for chemoreceptor sensitivity. You got stretch receptors and J receptors and irritant receptors through the airways, lower airways, and the lung tissue. And certainly you've got intracranial receptors as well, paraventricular receptors, and all these integrate oxygen and capnometry inputs and influence the drive to breathe. So any imbalances in all of these areas because of a neurologic hit can lead to sleep disorder breathing. Okay. So what happens with muscle weakness? We know that given in a significant enough presence or amount, the respiratory muscle weakness will lead to respiratory insufficiency. Now, what makes it unique in children is that they have not yet grown fully their chest wall or their lung volumes. So it's different when you take, for example, an adult who has a spinal cord injury who has completely grown their chest wall. It's a very different consequence compared to a child who develops a muscle weakness early on in life under the age of 2 or 3, or develops other neurologic injury and has not yet had a chance to grow the chest wall. So what I've done is, for simplicity, I've actually delineated changes to the lung tissue on one side and changes to the chest wall structure on the other side. And what we find is that we know that clinically that recurrent respiratory pathologies occur with respiratory muscle weakness. There's a repeated presence of atelectasis and are often viewed on an image or X-ray as a recurrent pneumonia. Over time, there is some scarring that develops, and that leads to changes in lung compliance or the change in the elasticity of the lung. In addition, you have the development of chest wall deformities that occur because of reduced lung expansion. And I'm going to give you some examples on what drives some of that for improved clarity. As a result, even the chest wall compliance begins to change. That means now both the lung and the chest wall start behaving very stiffly. So that three-dimensional excursion that we talked about now becomes maybe a one-dimensional, which means it's primarily the diaphragm that's going to do the work, and you're not going to get much displacement of the chest wall. You have diseases like Duchenne's cardiomyopathies, where you will have additional pulmonary congestion, or even if you're looking at left heart failure syndromes, whenever these occur, there's increased pulmonary congestion, the lung compliance decreases, and there's a greater propensity to experience or to witness atelectasis or repeated recurrent infections. And last but not the least, you can get changes in ventilatory drive. For example, if you have a traumatic brain injury that subsequently leads to a neuromuscular pathology. And then all of these begin to play on each other once each one of them gets established to a certain degree and begins to play on each other. So this is a clinical, this is one of our patients who at 18 months, 4 years, and at 7 years of age, I kind of cataloged their chest x-rays and put it together. But what I want you to see is a few things. One is you've got a certain degree of chest wall. This is a child with SMA2, a weak SMA2, spinal muscular atrophy. And what you see is very nice open intercostal space. You've got a central spinal column and a reasonable retrocardiac space of air, or a retrosternal or precordial air space, which is appropriate. And as the child gets older, you're seeing growth, but you're seeing the spine begin to buckle until about 7 years. So what you're seeing is a situation by which the child is growing by physically, but the lung volumes, you look at the chest wall height, is not really increasing that much. And as a result, you start seeing buckling of the spine. So clinically, what I see is I see children begin to experience significant spinal deformities in the presence of neuromuscular pathology between about 5 and 7 years of age when they experience a period of rapid growth, and again, shortly around the time before or during adolescence. This is, when you look at the spectrum from a simplistic point of view, David Grzal in the year 2000 had he's one of the prominent sleep physicians in the field. had written a review on neuromuscular disorders and respiration, and he categorized these pathologies in a very simple manner. There's a beautiful table that he had in his book, in this chapter, but he categorizes as muscular dystrophies, such as congenital muscular dystrophy or Duchenne muscular dystrophy. They're all fairly unique disease substrates. Then there are the metabolic and congenital myopathies, the kids with Pompe's disease, other mitochondrial disorders. Then you have neuromuscular junction disorders. As rare as it may seem, we do see some myasthenic syndromes in pediatrics as well, some congenital myasthenics, and those are your classical neuromuscular junction disorders. Peripheral neuropathies like Charcot-Marie-Tooth are known to present with significant spinal issues. And then anterior horn cell disease, also known as SMA, spinal muscular atrophy. But the one part that people forget to think of is the acquired forms. So acute transverse myelitis syndromes, traumatic brain injury, shaken babies or non-accidental brain injuries, vehicular accidents, hypoxic ischemic injuries, whether they occur as part of perinatal hypoxia. All of those can be forms of neuromuscular pathology in the first few years of life as well. So, in the adult sphere, I picked this right off the MDA website in Canada, and they see a slightly different pathology space spectrum, and they also have far more other, listed a variety of other additional disorders. Emery-Dreifuss is one of those, facialoscapular, Friedreich's ataxia, GBS syndromes, limb-girdle muscular dystrophies. These are the more common ones, and the ones in light gray are your much rarer presentations. So, Pompe's, myositis presentations, all of those can have neuromuscular presentations. Now, the important thing is your evaluation for these patients may suggest that these patients look well when they come to you and they are feeling at their best. But the moment you subject these patients to fever or stress, they become very catabolic. Once they become very catabolic, if they have limited respiratory reserve, they can't meet those catabolic needs. And as a result, they experience respiratory failure during those moments of time. So I always explain to my families and patients, any fever needs to be addressed very aggressively. And this is absolutely true for patients with mitochondrial disorders where the energy metabolisms are deranged. So what are the physiologic observations we see, right? So your physiologic observation starts when you enter the room. So this young man, Elemensak, is actually a different type of congenital muscular dystrophy, a Fukuyama type of congenital muscular dystrophy. And as you can see, he almost looks like he is working out and looks like a very well-endowed muscular individual, but actually that's a severe amount of muscle weakness and contracture. These images in the center in black and white are of collagen 6 congenital muscular dystrophy. And these patients present with elbow contractures. They can't straighten out their elbows. They're usually toe walking at a younger age. And some of these patients actually are predisposed to developing keloids. In younger kids, you can actually have very flat feet. And some adults, the Bethlehem type, which is the mildest form of collagen 6 congenital muscular dystrophy, actually will present in this day and age with difficulty typing because they can't approximate their fingers very closely when they bring their hands together, and because of the contractures between the interphalangeal joints, they have difficulty typing. This is a boy with Duchenne muscular dystrophy, and you can see the classic pseudohypertrophy of the calf muscles, and then frog-like positioning of a child with a congenital myopathy, which in this case was SMA. This young girl also has a form of congenital muscular dystrophy, and this is a classic facies that we see, and that is a merosin deficient congenital muscular dystrophy. Now, as you walk in, seeing the ambulatory status of these patients is important. Understanding what weaknesses they are experiencing is important. And then when you look at the respiratory pattern for these patients, it's really important to try and assess their tidal respiration. This is a video of one of my Duchenne boys, and surprisingly, look at the chest rise. It's absent, right? So that's maximal breathing, and you can see entirely only abdominal breathing, not the classic thoraco-abdominal respiration that we would be accustomed to seeing. So what are the other physiologic observations we look at? We look at pulmonary functions. And so I just have a couple of slides. As a pulmonologist, we always have to talk about pulmonary functions, right? So when you look at lung volumes and capacities in these patients, what you're going to see is there's going to be a constriction of the floor and the ceiling of your vital capacity, right? So this diagram may be familiar to many of you, but I'll just review it. So your vital capacity is made up of a combination of your tidal volume, which is what you breathe at rest. Anything above that inspiration is your inspiratory reserve volume, which is what you tap into when you decide to walk faster, run up a flight of steps. And your ERV, which is what you do when you are exhaling, say after a forceful cough and you have exhaled, you feel like all the way down to residual volume, which is your RV. So the combination of all of these is what you can physically engage in is your vital capacity. So very often when these patients become wheelchair dependent, they are not able to exercise, they're not able to run, jump, play, which is really important for the development of chest wall structure and for developing maximal capacities. If you don't exercise a joint, it's going to get contractured. So if I cast your arm and I take it off after 6 weeks, but I've only given you limited mobility within the cast, you will only have a limited mobility after I take the cast off. So children who don't run, jump, and play and don't experience the maximal range of motion of the costovertebral joints or the at the sternal and the vertebral ends are going to experience contractures over there. And as a result, we start seeing a reduction in the peaks of the IRV or ERVs, and that is how the vital capacity begins to get contracted in these patients. Scoliosis also adds to that, right? But you will see that the RV to TLC ratio will look a little larger, and that is because of the reduction in your vital capacity, even though the RV stays about the same. It's only at very severe states of contraction that the residual volume may appear reduced. The flow rates of these patients also begin to decrease. So when you do pulmonary function tests, you don't really appreciate a classic flow volume loop, and I'll explain that to you in the next slide, because of muscle weakness. And if you ever see a change in vital capacity from upright to sitting position of more than 25%, this is adult data. It's indicative of diaphragmatic dysfunction until proven otherwise. So when I talk about the flow volume loop, what do I mean? This is your typical, in a flow volume loop, from the machine perspective, this is the expiratory portion of it, and that's your inspiratory portion. So in your peak flow, you would expect to see a peak flow that goes up all the way and then comes down very, smoothly, and then takes a deep, smooth inhalation. So what you find is that your peak is going to be lower. Instead of being up here, it's much lower. Also, it takes a little longer to come to your peak flow. It may not be a 1 second, FEV1 typically occurs. So your peak flow should occur in the first 1/2 of a second or so, but you may exceed it prolonged. The other interesting thing that you see is this flow, the inspiratory flow drops off very rapidly towards the end of inspiration. And then lastly, you may actually experience flattening of the inspiratory volume. And sometimes that may be due to weakness of the inspiratory, your vocal cords, upper airway muscles during a maximal inspiratory effort. So this is one of our patients who actually has severe congenital muscular dystrophy, or Ulrich's congenital muscular dystrophy. And what you see is that the FEV1 is certainly reduced at 34%, but so is the FVC. And I see a lot of patients referred to us where this is still called an obstructive pattern, when your FEV1 to FVC ratio is still normal. So if both of them are restricted, if both of them are decreased, then that is definitely a restrictive pattern. The peak expiratory flow is also reduced because of muscle weakness. And then when you look at the maximal inspiratory and expiratory pressures, so it's important that you also measure maximal inspiratory and expiratory pressures. Those are also severely reduced in this patient. Now, in his case, we also did lung volumes. And here's where I say that although his total lung capacity was at 54%, his residual volume was still 80% of normal, so not very reduced. And that is why the RV to TLC ratio appeared much greater at 56% as opposed to 20 to 25% of where would be expected. And when you look at your flow volume loop, you can see how small and low that is, right? So another diagram that you may be familiar with, what happens during tidal breathing? We normally at FRC, which is between inspiration and expiration during tidal breath, have a negative pleural pressure of about -4 to -5 centimeters of water pressure. With contraction of chest wall muscles, mostly isometric, and then active contraction of the diaphragm, you begin to experience a more negative intrapleural pressure, which facilitates inspiration until the gradient between the alveolus and atmospheric pressure has been eliminated at the end of a normal tidal breath. And then the recoil of the chest wall kicks in at the end of that for a normal passive exhalation until the next cycle begins. What happens with chest wall muscle weakness is that your ability to maintain this negative pleural pressure decreases over time. So you experience diaphragmatic weakness, you experience intercostal and pectoral muscle weakness, strap muscle weakness. All of that makes it very difficult for the chest wall to have that typical recoil it used to have. And therefore, the alveolar forces of surface tension begin to have an aggregate, more of a greater aggregate effect, and you start experiencing lower lung volume states. When you experience lower lung volume states, eventually you hit a certain point at which surface tension increases to the point of atelectasis. And what the body does is it tends to sacrifice certain lung volume units so that it displaces air into other alveolar units to maintain reasonable amounts of surface tension in those lung units. That is really important in trying to reduce your work of breathing on a breath-to-breath basis. So atelectasis begins to set in as you have chest wall muscle weakness. Now, once you have muscle weakness, what happens when you go from a vertical to a recumbent position? In the vertical position, gravity still acted in a downward manner, and so the bowel contents fell off the diaphragm, and tidal excursion was relatively unimpeded. What happens when you lay down is that gravity still acts in a downward manner, but all the abdominal contents now push the diaphragm to a much higher resting position. As a result, lung volume decreases and tidal volumes begin to decrease. Okay, so how important is tidal volume? Well, if you think about a typical tidal volume of 500 ml, 350 is what is available for alveolar ventilation because 150 goes to dead space. Dead space is all of the air that does not take part in air exchange. When that happens and you start experiencing lower tidal volumes, what occurs is a progressive reduction in your effective alveolar volume because the tidal volume, the dead space, will still take its pound of flesh from the tidal volume. And so, even though you may experience a 20 or even a 40% reduction in tidal volume, if your tidal volume went from 500 to 300, your net alveolar reduction went from 350 to 150, which is a 57%, almost 60% reduction. And this is really important to understand when you're thinking of volume control modes for your patients, and you forget to think about dead space ventilation in the circuit, in the hose, to the patient, in the mask, all of those things. So ventilation needs tidal, and when is the tidal volume appropriate? When you see enough of thoraco-abdominal excursion. I tell people, don't stick with a number. Look at the patient and see what is optimal for tidal volume. So I wanted to, highlight something very interesting. This is a muscular dystrophy with myositis mouse model that looked at early dysfunctional diaphragm in this titinopathy model. So there is the wild type. At 2 weeks, you can't see the difference between the wild type and the muscular dystrophy model at all. But what happens at 6 weeks of age is that the MDM model, the muscular dystrophy model, has severe hind limb wasting, spine deformity, and is non-ambulatory largely, and certainly is also smaller. Now imagine this is for a horizontal animal, let alone what would happen in a vertical individual like a child or an adult, right, with low lung volumes. So what they did was they did 3D micro CTs, and what you can see is that 2 weeks on the left, you've got the wild type in the first column, and then the second column has the MDM model. There's not that much of a difference between the two at 2 weeks of age, but you do see a smaller diaphragm and slight change in the diaphragm configuration beginning to set in. But at 6 weeks, you are seeing far more established thoracic dystrophy over here. Now let's take a second to think about, I actually usually carry a syringe with me when I'm in clinic, just so I can explain a point to families. If you consider the chest wall to be the syringe, the plunger on the syringe is going to be your diaphragm. So any excursion of this chest wall, of this diaphragm, is going to lead to inflow or expiratory flow in the syringe. Everything is good as long as you have a wall that is rigid. If this syringe was made of plastic, thinner plastic or paper, and I try to pull this plunger down, this whole thing would implode. And the reason is because there's not enough structural rigidity to hold this up in the presence of a negative pressure. Now, if you think about it, patients who have muscle weakness have weaker bones. So as a result, they are more likely to experience bone malformation because of disuse, atrophy of muscles, or lack of muscular action on a bone. Let's go back to where I talked about casting your arm. If I put your arm in a cast and took an X-ray 6 weeks later, it will, even in the absence of bone of a fracture, you would experience marked difference in bone density between the right and the left arm, because the left arm bone density stayed normal because you continue to use it and had muscles acting on the bone. If I casted this arm, not only would the bone density decrease, but you would probably have muscle weakness from not using the muscles for that period of time. So muscles really influence bone shape, bone form, bone density. And the same is true for the ribs. And that's how you get a lot of chest wall deformity, particularly in kids with SMA1 or, other congenital myopathies. Now, if you think about this, the chest now has significant asymmetry at 6 weeks of age in this animal model. We know from clinical experience that people with muscle weakness start becoming shallower and faster in their breathing. So that means your respiratory cycle time decreases, which means air is going to flow to the areas of least resistance or most compliance. So what's going to happen in this animal model is in every single breath, airflow is going to occur primarily to the left hemithorax more than the right hemithorax, because it takes more energy to deform and inflate the right lung against a right hemithorax, which is deformed. And as a result, that spine deformity and rib deformity, once it has set in, it will accelerate because of almost unilateral lung use as opposed to bilateral. Is that clear? The other part that I also want to explain, what happens to the diaphragm is this. If this is your normal diaphragm and it moves through a full range of motion, up to down, when you have scoliosis, you have rotation of the vertebral bodies. That's what scoliosis is. It's not the curve, just a left to right curve. It's actual rotation of the vertebral bodies. That's why you see a hemithorax becomes more prominent in the back and diametrically opposite becomes flat. And that's because of rotation of the ribs. And the similar thing is occurring in this last image on the lower right corner, where you are seeing a rotational deformity over here. So what's happened is your diaphragm, which used to be this, is now like this. So it can't function effectively. So if you have a dysfunctional diaphragm on that hemithorax, it's going to reduce tidal volume to that side. It's going to reduce your net deflection and negative pleural pressure. It's also going to reduce your cough efficiency. You can't take a deep enough breath in order to cough it out. Okay? And that is why we also see stasis of secretions and encumbrance of secretions in these patients. Well, we covered this already. So what happens if you get reduced lung volumes? When you have a low tidal volume, you start experiencing hypoventilation. Because when we breathe, we do two things. You breathe in, you oxygenate. You breathe out, you ventilate. You get rid of the stale air when you ventilate, right? You go home after you've been away for a month, you open up the windows because you want to air out the house. You want to get rid of the stale air. So you are ventilating the house. So whenever you have low lung volumes, you're likely to experience hypoventilation. In addition, air displaces mucus, and if you don't have enough airflow, you're going to have impeded airway clearance. And that is where you will also get increased work of breathing from atelectasis and collapse. Now, those of you will remember that you will also experience lower alveolar volumes. There's a law in physics and physiology also called Laplace's law, that the surface tension of the alveolus is inversely proportional to the fourth power of the radius. So the moment your radius begins to decrease, the surface tension begins to increase very rapidly until that lung unit collapses. That also leads to increased work of breathing. Last but not the least, the previous images in the animal model give you an idea of the thoracic deformities that can come up. So what is the use of polysomnography in patients with neuromuscular disease? It's been very well established that respiratory muscle weakness does lead to sleep disorder breathing, which means disruption of ventilation and oxygenation and sleep architecture in sleep. And this leads to daytime symptoms, often very early on. And these patients can present actually with frequent nocturnal awakenings and insomnia. So parents may say he doesn't sleep, but that's the body saying, wake up, breathe, repeatedly through the night. Polysomnography is really important in diagnosing or detecting sleep disorder breathing early in these patients. And therefore, it allows the early initiation of non-invasive positive pressure ventilation or bilevel pressure ventilation for these patients. And this has been clearly shown to improve quality of life, longevity, and survival in these patients. This is taken out of one of the sleep medicine books. This is actually an adult who had presented with headaches and insomnia, and this had an underlying diagnosis of early ALS, Lou Gehrig's disease. And what you see here in the classic polysomnography is there are eye leads over here, There are a few limited EEG leads. There's the chin EMG, EKG, or ECG with a heart rate monitor. There's a snore channel. There's a nasal pressure transducer. There's an active thermocouple that detects airflow at the nose. Chest and abdominal belts, or what we call impedance plethysmography. A pulse oximeter, and then they use 2 channels of carbon dioxide, which is end-tidal as well as transcutaneous. So in this case, it's 1 channel with just the end-tidal signal over here, the PCO2 waveform, but we can also use transcutaneous, and I'll show you some epochs in that regard. And what you see here is saturations that maybe dip a little bit to the 95 range, but again, back up to 98. And this is what happens. What happened is the CO2 was in the 50s, and somebody put this patient on oxygen, and you can see right away how the carbon dioxide climbs into the 90s with the use of supplemental oxygen. That was the point I wanted to make on this, is that supplemental oxygen is not the treatment for respiratory muscle weakness. So what happens, as we know that our sleep is comprised of dream sleep and non-dream sleep, or REM sleep and non-REM sleep. So what happens during non-REM sleep? It's often the easiest to discuss. We see phasic diaphragmatic EMG, intercostal and genioglossus in the tongue activity decrease with sleep onset. And then it increases a little bit during stage 2, stage 3 of sleep, but not that much. There is a phasic and tonic reduction of the oropharyngeal muscles. The tensor palati tone decreases. So pharyngeal volume decreases, and there's a slight increase in PCO2 with sleep onset. And there may be the combined effect of this reduction of the pharyngeal muscle tone can actually increase your upper airway resistance during sleep onset, and again later in slow wave sleep. Now, what happens in REM sleep is even more interesting. You have complete muscle atonia during REM sleep, except for the ocular muscles and diaphragm muscles. And as a result, because of that, you have a further reduction in your tidal volume, your minute ventilation, and your inspiratory flow. And so if you're going to see sleep disorder breathing, you're going to see it much more so during dream sleep in these patients. And that's why many of these patients don't really dream. And when you put them on support, they get dream rebound, and they'll come back and tell you of all the dreams that they experienced. And what we see is a smaller reduction in tidal volume, a higher frequency of respiration, but still have a lower minute ventilation. And there's a nice study that was done in normal adults that looks at different stages of sleep. This is wake, stage 2 of non-REM, and stage 3 or 4, or what we call slow wave sleep of non-REM. And then there is REM sleep. They broke up the REM sleep again into tonic and phasic REM. And what you're seeing is that broadly, as far as minute ventilation is concerned, we know that minute ventilation drops with sleep onset. But the largest drop of, it drops, but it stays fairly stable during non-REM sleep. During REM sleep, the tidal volume decreases and the respiratory rate increases. And this is seen mostly during phasic sleep, phasic REM sleep, these dramatic changes. And I'm going to show you some epochs in sleep to actually show that. So when we talk about sleep architecture, because sleep is broken up because of repeated awakenings at night, these patients tend to come to you with some semblance of sleep deprivation. So there is reduced sleep time because much time is spent awake at night, and therefore the sleep efficiency as a percentage is decreased. There's increased sleep fragmentation, and our sense is that this is much more adaptive because it's the body telling them to spend less time during dream sleep and more time either awake or in light sleep, which tends to be life preserving because the body is very heavily stressed when you subject it to repeated apneas and hypopneas during sleep. There is REM-related hypoventilation and desaturation, and later that spills over into non-REM sleep, and finally it spills over into awake as well. You see paradoxical respiration without narrowing of the upper airway, and this is a very important finding when we look at sleep studies in these patients. So what do I mean by that? Well, I'm trying to describe what is called a central hypopnea. Central hypopneas are reductions in effort with reductions in airflow. So you get marked reduction in tidal volume. You often see this during dream sleep. And the degree of desaturation that you see is likely related to the degree of diaphragm weakness. Why? Because if you're experiencing most of these during REM sleep and you're desaturating more, then you have to think that if the diaphragm was the primarily muscle of respiration during REM sleep, and I'm still experiencing hypoventilation or hypoxia, that tells me that the diaphragm is fairly affected during REM sleep. And so this is, schematically, this is what it would look like. You'd see chest wall and abdominal excursion, and then they'll flatten out. Then again, they will increase, again, they will flatten out. And so it takes a cyclic pattern, and I'll show you a couple of epochs of how that looks like. What about oxygenation? So you can get desaturation of sleep due to hypoventilation. That means the CO2 goes up. And this is very basic, simple math, the application of the alveolar gas equation. You can get repeated apneas and hypopneas, which is reduction in the upper airway opening. And then you get VQ mismatch if there's atelectasis that is occurring as a result of reduced chest wall muscle tone. Most profound destabilization of saturations in oximetry occurs during REM sleep. So are there any clinical predictors? If you were to ask your patients, there's a lot of text on this slide, and I'll show you, this is one of the few, we're coming to a point where I think I'm going to run out of slides with text, and the rest of my slides are going to be images because it's late enough for you. You don't need that much reading material. But I essentially summarized the study that came out of Stanford, one of the earliest studies in '94, where they took a mixed bag of patients with neuromuscular disorders. There was adults, there were pediatric patients, there were males, females, and a variety of diseases. And essentially they could not find anything conclusive to say that so-and-so has, these symptoms are specifically predictive of sleep disorder breathing. So what's the role of pulmonary functions as you as a clinician, right? This data came out of Australia, looking at an older subset of Duchenne boys on young men of 19 boys. And what they found was that an FEV1 of basically 40% FEV1, a PCO2 of greater than 45 millimeters of mercury, and a base excess of 4 are very sensitive indicators for sleep disorder breathing. An FEV1 less than 20% correlated very strongly with daytime hypoventilation. So these are the two things that you could probably remember. And maximal inspiratory and expiratory pressures and total lung capacities don't really give you a good idea of the presence or absence of sleep disorder breathing. So this is the same paper. This is another paper published shortly around that time. And they looked at supine vital capacities. And what I just want to show you is that patients, as their lung function decreases, what I want to share with you is that initially they will experience hypopneas, which is reduction in the caliber of the airway with some desaturations in sleep, or have an arousal, that means sleep disruption. Then they continue to have that, they experience REM sleep-related hypoventilation. Later on, it is continuous hypoventilation, and finally it's respiratory failure, where they remain hypercapnic continuously with vital capacities of 25% or 40%, depending on where they are. Now, mind you, this is supine vital capacity. I wish I could do supine lung functions here, but I can't. This is a study that we did some years ago at our center, and we had 110 boys, younger, and these were all steroid-treated, glucocorticoid-treated boys. Their lung function was about 79.5%. And you can see they're not obese, but they're a little heading towards overweight. And what we saw was that these patients experienced a great degree, almost 64% of patients experienced obstructive sleep apnea. And the few that experienced central sleep apnea. The central sleep apnea here was severe obstructive with central sleep apnea. And a very small percentage experienced pure hypoventilation, which is something you see in very established disease. But 17% of patients is a fairly decent amount to experience hypoventilation at such an early age. And what we found was there was a fairly linear correlation between the degree of sleep disorder breathing or the degree of obstructive apnea, the obstructive index, with their BMI. So if you have a BMI of greater than 24 in your patients who are steroid treated with Duchenne, even if they are 12 or 13 years of age, I would think that they need a screening sleep study because that is likely going to yield a diagnosis of sleep apnea that is worse during REM sleep. And so that's the other thing that we find is that when looking at the obstructive index, it can be fairly severe during REM sleep in these patients. So coming back to this diagnosis, this adult, so looking for tachypnea, particularly in the recumbent position, hypoxia, and hypercapnia. So the definition of hypoventilation or hypercapnia has been a bit of an issue in the sleep population. And we are in the process now with different colleagues across the world working on defining what hypoventilation should look like when it comes to neuromuscular disease. Because by the time patients have frank hypoventilation in sleep, the disease is so established and sleep disorder breathing is so well established in these patients. Then this is what happens when, this is the same slide I showed you earlier, when he was put on supplemental oxygen, and you can see the CO2 increase from the 50s right into the 90s on end-tidal CO2. So this is a study over here, an epoch. This is a 1 minute epoch. This line in the center is 30-second mark of an individual. He was a teenage boy with Duchenne muscular dystrophy during REM sleep. So here in blue, you've got oculogram. This shows you the rapid eye movements that are occurring during phasic REM sleep. And this here, you're not seeing it. So this is what we would call tonic REM sleep. And here you can see the thoracoabdominal excursion decreases, and you're seeing a loss in airflow. And this is how a respiratory event is identified. The saturations are 100%. You're seeing some disruption in your carbon dioxide level, and it actually decreases because you're having decreased airflow. If your airway caliber decreases and it's impacting ventilation, you may actually have a decrease in your end-tidal CO2, and when respiration resumes, it'll bounce back up. And the patient is a little tachypnic. So it's important that we familiarize have reasonable expectations of what the respiratory rate should be for individuals of a certain age. This is another epoch, and you can see an obstructive hypopnea, which is partial reduction in airflow, or a much more significant reduction in airflow where it's obliterated completely. And that, again, occurs during REM sleep, as you can see. They tend to have more significant phenomena there. Again, a tachypnic patient. Here again, you will see this is someone who's breathing 30 times a minute, is experiencing REM sleep, lots of REM, rapid eye movements, and even though the oxygen levels are fine and the carbon dioxide levels are fine, for someone to breathe 30 times a minute to maintain normal carbon dioxide level is not normal, especially if they're a teenager. So I always try and look for that. It's important that we try and look for, when you hear, there's a saying, you hear hoof beats, you think of horses, but sometimes you have to think of zebras. So this is actually, it's not a very clear slide because of just how I think we saved it. But you're seeing a reduction in airflow amplitude. You see some respiratory paradox, not too much, and then it resumes over here. Now, I didn't mark an arousal over here, but this is now a 90-second epoch. This is 30 seconds, this is 30 seconds, this is 30. Look and see when I zoom out now to like 5 minutes, 3 minutes. And you can see this phasic crescendo decrescendo pattern of respiration. Almost looks periodic breathing. This is again what we call central hypopneas, where I said central versus obstructive hypopneas. Obstructive hypopneas won't occur in a similar sequential manner. This is central hypopnea. And you can sometimes see this with heart failure as well in patients with significant cardiomyopathy. This is a patient with SMA1 who came for a ventilator, a BiPAP titration. And you can see while awake, the patient is tachypnic with a respiratory rate of 52 a minute. That's the capnometry. Now it's important that we always have a plateau for our capnometry. This is a very poor signal. And that's why the end-tidal capnometry looks like it's in the 30s, but the transcutaneous CO2 looks like it is in the 50s. So this is where the importance of having good quality signals are important in interpreting a sleep study. And once this patient has been situated on full vent support, you can make out, you have a good signal of flow, bilevels. The respiratory paradox that you had earlier is gone, and the patient is completely dependent on the ventilator support, which is set at 24/5 centimeters of water pressure and a full backup rate, which is age appropriate. You can see while awake, you see intercostal activity from the exertion of this patient, but you don't see any of that while awake. And that's a sign that your patient is adequately supported. Over here, you're seeing a little snore channel come in, and that is actually because the leak from the mask increased momentarily, and it can look like a leak, can look like snoring. And if you have a big enough leak, you can actually lose pressure and precipitate respiratory events. So doing these studies comes with the responsibility of educating families on how to fit the mask and make sure that they have a good fit. So why bilevel pressures and not continuous positive airway pressure? So if you schematically, if you look at our current respiratory pattern, we have a nice sinusoidal pattern. We know that individuals with respiratory weakness experience shallower breaths and faster breathing. So what bilevel pressures do is the lower pressure, or the EPAP, helps maintain a patent airway. Let me back up. If someone is going to experience a respiratory event after a normal breath, it is going to occur when the inhalation is done and it's at the end of exhalation. During that time, the airway caliber is decreasing, and when they want to take a breath in and the airway has not opened up, that's where you experience obstructive hypopnea. So when you give an expiratory positive airway pressure, or an EPAP, it stents open the airway pneumatically. So if this was a non-neuromuscular individual, CPAP would act like a pneumatic stent and stent open the airway and allow them to breathe through. But what we do need to do is enhance the size of this breath, or augment the inspiration. And that's why we need a secondary level that will cycle off and allow the patient to inhale, to exhale. Then again, it will arrive and give them a tidal breath. When you support the patient with an optimal tidal volume, the patient will decide to stop breathing effectively, and they will become largely dependent on the ventilator during sleep. That is reasonable, and it's expected because you want to provide respiratory muscle rest. And that is how their daytime function improves, because they're not working hard in sleep and they're not working hard awake. They're better rested during sleep so that they can function normally while awake. Okay? So bilevel pressures are really important in supporting ventilation, along with a backup rate. You cannot do it without, all three need to be a part: an EPAP, an IPAP, and a rate, with a designated I time. So when you look at this progress through the night, where we titrate pressures on patients, your EPAP is driven primarily to treat obstructive apneas. And as the night progresses, you will increase your IPAP for hypopneas or related arousals, and then any residual snoring. And during early morning hours, they may experience some REM sleep rebound and have some more apneas, and you may need to go back up on your EPAP by another 1 or 2 centimeters of water pressure. But by and large, the last thing to be eliminated for these patients is a phenomena what we call flow limitation, where they just need to have a better waveform after you've eliminated events, so that you prevent overcorrection or over titration of these patients. So the role of adequate pressure support is really key. If you want these patients to do well, you know, I kind of got these images from the polio days back in the United States, where they actually had rooms that were built as negative pressure ventilators. And this is how patients shared a single ventilator chamber. They all were on the same pressures at the same time, with only their necks sticking out. And then the nurse would attend to them. These are individual patients, much like how we would have in our wards, in their individual iron lungs, as they would call them in those days. This is a negative pressure ventilator that is, you know, there's only one company that makes this, and they have a monopoly. I have not used it. We've tried it a few times without much good success. And then you have a variety of positive airway pressure devices depending on the company or the brand that you have, whether it's Respironics, it's Philips Respironics or ResMed, any of these equipment. So positive pressure has a role. This is a child who has BPD, has a tracheostomy, as you can see, and you can see fairly good lung volumes. And more importantly, you can see a horizontal apposition of the ribs in relation to the vertical axis of the spine. You start seeing, this is a child with SMA1, and you can see now there's no muscle at all in the chest wall or in the arms, all fat. You see a beginning of a decline, as I would say, or de-inclination of the ribs in relation to the vertebral axis. And also these ribs look extremely osteopenic, or gracile is the word. Like some of these ribs you can barely see. This is the patient progressing as they get older with a reduction in the anterolateral diameters of the chest wall. And you start seeing imploding of the anterolateral spaces. And so what happens, they look like they have pectus carinatum, when actually you've got retraction of the anterolateral chest wall. And then the same patient progresses further to have complete collapse of, you know, one lung. On the other hand, this is an infant with the same, and you can see there's no chest wall muscle at all. Here is an infant who is a child who was actually received a tracheostomy and ventilator in infancy in the nursery with SMA1, and the child was never admitted. So you can see the ribs are still very gracile, and there is still scoliosis because of growth, but the rib deformities that I showed you earlier are non-existent, right? So what you're seeing is the effect of pressurization when you optimally support patients. Now I'm going to give you another example. This is a little girl of mine. She came to us with congenital myopathy at about 6 months of age, just with a tracheostomy. And the nursery where she was in just said, go home and take care of her. She came lethargic, and her CO2 when she got admitted was about 75. We put her on a ventilator. 2 months later, she went home. I got a CT on her before she went home, and this is her chest wall. You can see her AP diameter is greater than her lateral diameter. But at 3 years, she has a completely normal configuration of the chest wall because she was pressurized optimally. We see children who are born with one lung, normal chest wall structure otherwise, no muscle weakness, but they still develop scoliosis to the side where there is no movement because there's no lung. That tells you the lung plays a very big role in deciding the shape of the chest wall. And if we don't pressurize these children appropriately, they are going to experience severe chest wall dystrophy or dysmorphism, which is going to be associated with great degree of morbidity and mortality. children who have large adenoids or tonsils will develop adenoid facies. That tells you that airflow is really important in developing the maxilla and frontal bones. And if you don't have good normal airflow, you're not going to develop good bone structure. So all I want to say is that in patients with muscle weakness, where chest wall structures are weaker, the ribs are softer and weaker, and the drive to breathe may be suboptimal with muscle weakness of the upper airway, pressurize them appropriately with the hope that, patients like this, if she has a cure coming up, she could potentially come off the ventilator if she had enough of chest walls, a normal shape. With good form comes good function. And I'll end there.
Thank you, Dr. Hemant. It was a wonderful and an elaborate too, and an easy, simple lecture, which made neuromuscular disease as simple as what we have not known. Because I've experienced working with you, I was there in Cincinnati in 2015 for a month's time. And because of Dr. Bob Wood, I got a fellowship in Australia. I took a letter of recommendation from him. So it was so nice that you have made the topic so simple. So if you stop sharing, I would just ask a couple of questions who have been.
Yeah, I'm trying to actually get out of that. Oh, right here. Go ahead.
Now, there's one of the interesting questions, because he is Dr. Victor he worked in GOSH with the neuromuscular team. So he's asking, is there any effect of drugs on respiratory sufficiency in neuromuscular disordered child?
Pavan, with your permission, can I allow the Victor in?
Yeah, definitely, sir.
Please. It'll be good to get some clarification of the question.
Dr. Victor, you can come in. Yeah, I think, sir, Hemant, sir, you continue. I can have a sip of water. No, relax. No, anyway. Yeah. Sir, you can continue.
It depends on, so I have a patient who has congenital myasthenic syndrome. And she had come to us at 4 years of age with the tracheostomy ventilator, getting worse. And they wanted to know for end of life if there was anything they could do. And I said, what's the diagnosis? And nobody knew. So one of my neurology colleagues came out of the room in 10 minutes, literally jumping like a child. And he made the diagnosis of congenital myasthenic syndrome in 10 minutes. We started the child on Mestinon, and she was off ventilator support for the day within a week. So to answer the question, I think the right diagnosis with the right drug, yes, there is an option to always do some good work there. But the broader question is, if you have some muscle structure that will respond to treatment, I think that is going to be the bare minimum requirement for a drug to take its effect and for you to see a measurable benefit. Okay.
So anybody in the audience who wants to ask the questions live, you can raise your hands. I can see and promote you into the panel. You can directly interact with sir.
Victor has raised his hand.
Victor, please speak now if you have any.
Hemant, there is one comment that there's a patient not a patient, is a Dr. Omi Narayan has commented that he's a sleep specialist in UK. He listened to your lecture and said you made the lecture so easy and for everyone to understand.
Pleasure. Thank you.
Dr. Subodh Gupta, you can ask your question.
Good evening, sir.
Please.
I want to know about the calpinopathy. These patients, how do they behave as far as respiratory physiology is concerned? Do they have the same disasters as we have in Duchenne type of, or they behave differently? What is your experience about calpinopathy?
Calcinopathies?
Calpinopathy. Calpinopathy, a variant of muscular dystrophy, congenital muscular dystrophy.
I'm not familiar with that specific form of congenital muscular dystrophy. But if it's one of the when you think about congenital muscular dystrophy, the thing that is unique from Duchenne, since you mentioned that, is these patients tend to have a greater degree of contractures than Duchenne patients early on in life. And that's very true for like the Merosins, especially the Merosin deficient ones, the Fukuyamas, the SEPIN1 congenital muscular dystrophies, the collagen 6 congenital muscular dystrophies, both the Ulrich as well as the intermediate forms. So all of those tend to develop very significant contractures. So if this form of muscular dystrophy is also similar to one of those dystroglycanopathies, then yes, they are likely to develop the same degree of contracture. This contracture involves chest wall as well as skeletal, axial skeletals. The other thing is, what's unique is that these patients can present with alveolar hypoventilation when they're still ambulatory, which again is unique for some of these congenital muscular dystrophies, especially the SEPIN ones and, especially the Merosin deficient and the collagen 6s. So this particular one that you mentioned, I'm not so sure if it falls very strongly in that, but I say if you don't see good chest wall mobility while awake, it's definitely going to be even less so while asleep.
Okay, sir. Okay. Thank you.
Sir, I have got a question. Like, let's say a preterm is there and a term is there and an older child is there, an adult is there and a geriatric is there. Now, how you would like to visualize the breathing physiology through the ages? And, what can be done to, explore the complete potential? I'm taking you from preterm. Maybe you can go up to in utero to the final death. So please,
So the in
something
utero
about
part,
physiology, because it's ultimately physiology that matters for us when we apply.
so I would say that the first few years, even in utero, as well as subsequently up to an age of about 5 to 7, the role of chest wall muscle strength is extremely important in the development of the shape of the chest. We have seen some patients with significant thoracic dystrophy born with thoracic dystrophy with some unknown myopathies in the background. Till today, we don't have a diagnosis. And they do tend to have severe respiratory failure as a result of that. If you look at a child who was born normally, normal shaped, and develops acute weakness later, either because of transverse myelitis or spinal cord injury or a head injury somewhere, then I would say that the type of underlying neuromyopathy determines what's going to happen. So children with spastic forms of cerebral palsy become so stiff that the chest doesn't move. And they clearly have a very severe form of restriction to respiration. Patients who are in, electrical status because of severe injuries or whatever. Conversely, the patients who are very hypotonic, lose chest wall compliance very quickly, become hypercompliant for a moment, and then become very tight in the chest later. It's almost like having a rigid cage on the chest wall. And patients who go through that period where they become hypercompliant and then lose compliance because of a delay in intervention are at greater risk of having respiratory failure. Those where you intervene early can be managed with very low settings even as they get older. The differences from a physiologic perspective are complex because of the interplay between intercostal muscles and diaphragm and the upper airway. What I found is that as you have more upper airway weakness, your risk of having deformity of the chest wall increases very quickly because they continue to try and inhale against the closed glottis. And you can try and do that like create a pseudo obstruction for yourself and try and inhale. And you can really feel a very negative interthoracic pressure being developed. And that's you who don't have muscle weakness. So in these individuals, when they're younger, the combination with a weaker rib cage is going to yield far more thoracic dystrophy. Now, when you look at an older individual, anything past the age of like 16, 15, 12 even, into adulthood, we do see the role of the chest wall formation becomes less significant. And any pathology over there is going to be driven almost exclusively by upper airway instability and muscle weakness. The form of the chest wall has already been established. And so, like if you have somebody who is 30 years old and has a spinal cord injury, it's unlikely they're going to develop significant spinal deformity in the next 10 years or so, because they've already fully grown. But what changes, depending on what age group you have after that, is respiratory drive. And as we age into adulthood, late adulthood, we're talking about 40s, 60s, the geriatric population, weakness of the upper airway, weakness of the trunk muscles is the norm. Okay, so understanding the process of aging and how we breathe is really important. And we see this in our own parents, that they gradually begin to sit slumped like this.
Yeah.
And so even eating normally for them actually is the equivalent of if I were to sit like this with my neck a little extended, but if I change my position, that same position now is actually almost eating hyperextended. So the neck position, you will see so many older people will choke on their food.
Yes.
And that is because of how they sit and they're trying to eat by still meeting eye to eye the folks across the table.
Yeah.
So it's important to educate them that they should sit better supported and keep the chin down when they eat. Because airway protection is a real big part of maintaining good pulmonary health. And aspiration is a big problem for people there.
So that tempts me to the next question, Pawan. Sorry, a couple of two continuity questions I wanted to ask. Sir,
Sure.
please tell us what is the normal breathing rate, which we call as respiratory rate, and what I'm going to ask you now is not what is abnormal. Let's say definition of tachypnea is not important to me. Let's say below that, what the normal range means. I will say,
Yeah.
for example, the normal range is 20 to 20 to 30 in a given age. What
So-
that 30 means and what that 20 means. Is that child at 20 better, or is that child at 29 better? I think I'm just dissecting something more of physiology.
Let me rephrase your question. Okay.
Okay.
If I were to say you have a minute ventilation, which is your tidal volume multiplied by your rate of a certain amount. So let's say somebody has a minute ventilation of 6 liters, that they're breathing 500 mils 12 times a minute.
Correct.
Okay. If I were to change that to the point that someone's breathing 100 mils 60 times a minute, that's not physiologic. Now, it may be okay for an infant or, into toddler, but it's certainly not normal for anybody past a certain age. So what I say is, I expect a normal age range of children that's age appropriate. Let's say an infant can anywhere be 40 to 60 a minute. But after the age of 3, I usually feel that the rates are in the upper 20s to low 30s after the age of 1. So anywhere from 28 to 32, 35 would be okay. You can only go by what seems like a normal range. The moment you hit early childhood, the tolerances decrease, and we say people need to be in the range of about, by the time they hit adolescence, I would expect people to have a range of 12 to 16. So younger children between 5 and 8 or 5 and 10, I would put in a range of, an upper limit of 20 to 24. So if I see a 16-year-old breathing 30 times a minute, to me, that's pathological.
Yeah.
Right? So that's interpreting what we are seeing needs to be in the context of the diagnosis.
Sir, why I asked this question was because suppose let us define the tachypnea by -10, then are we going, we may have some false positives of diagnosis of
Right.
tachypnea, all right.
So
But,
I use
will that reduce the mortality? My question is simple, by just defining it by less than 10, if we can improve the death rate, I mean, if we can prevent some people from dying, will it make sense?
I can tell you what, just to the first part of your question, we've chosen and we're trialing this, not looking at a rate of X amount, but looking at a rate of 25% or over from what is expected at baseline. That seems to be the range. So if I see someone who has an expected rate of about 20 to 24 a minute, but they're breathing 30 a minute, that's a 25% change, then I would say that's abnormal. Now, to the second part of your question, my answer would be yes, particularly if it's a progressive disease. Because you know that what you're seeing is only going to get worse. And you know that if you don't treat him now, there's a chance he's going to land up in the hospital more acutely sick. The problem is that when patients are acutely sick, they lose a lot more function. And so by the time they recover from that illness and get home, they may never be at that right baseline. So treating them in a timely manner, not too early. You can't do it when they don't have pathology. But as they're evolving, my answer is yes. If you treat, you're likely to gain much more function for a longer period of time. Second thing is you're preventing unnecessary hospitalization, which in the longer run is cheaper.
Cheaper.
Third, they're healthier, their quality of life is better, right? Fourth, it is less stressful on the parents and the family to not have fluctuations in health, from being well to be sick, be health to be sick. And lastly, if you know what to expect, you can, when you start around this age, before they're obviously sick, they have a little more time to adjust and participate in their care.
Sir, my apologies for continuing that question. Extrapolation of the same.
Yeah.
We have a lot of malnourished children in India.
Yes.
So therefore, I would assume that the thoracic cage, the muscles, everything must be definitely, much less efficient compared to their normally nourished counterparts.
Yeah.
So how best you think that, even in defining tachypnea, I've given a margin of 5. Is that fair? Should we define it by, for let's say, stage 1 PM, stage 2 PM, stage 3?
I would still stay with the percentages. So our pediatric textbooks or Harriet Lane's, they all have normative ranges. And I would tell you, stay with the percentage. It's going to give you a better cushion.
Better position than the count.
Than the count.
Excellent.
Because the count of 5 may mean nothing for a child who's 2, but a count of 5 could mean something for someone who's 25. So I would say go by percentage, and you're going to be on safer ground.
Yeah. So my apologies for Indianizing your, experience to help our children. So
not at all.
To Pawan for asking.
Children are children. I don't. They're just as important, regardless of their zip code.
Yeah. Pawan, continue. Other questions.
So the question what Victor Germon was asking was the steroids on DMD, nusinersen on SMA. Are they effective to postpone or improve the respiratory insufficiency?
So the first part, the steroids in Duchenne, we actually just published that paper last year in Pediatric Pulmonology, where I corroborated our data of steroid treated with a cohort with Brigitte Ferrou in France of steroid naive patients. What we've shown is that the rates of decline are parallel, but the height at which steroid treated patients start from is much higher than the steroid naive patients. So when you start your decline from a much higher function, you are going to take much longer to get to a critical lung volume or vital capacity. The second thing is so steroids are not a cure, they only postpone. And that too, I would say that ranges, certainly it's about 3 years in terms of the postponement, but they allow children to reach much higher peaks of lung function. Nusinersen is, when timed right in early infancy for children, I've seen some benefit. I will not say I've seen any benefit past the age of 3 or 4 in any of our patients. And I've been getting some CTs here and there. I'm not seeing any change in muscle mass of the chest or the back. I'm seeing families who say, "Oh, now he can do this." They're seeing that as quality of life, but I'm sorry, but I don't see any pulmonary function improved with nusinersen.
The second question is, do you think the PFT is necessary in neuromuscular kids, as sleep study is much more sensitive in detecting the restrictive lung disease?
So I think in neuromuscular disease, pulmonary functions are important to establish a baseline and to understand where your patient is going. It is also, for me, it is an indicator of when I need to study my Duchenne boys. So if I see lung function of a certain degree at a certain age with a certain BMI, I know I'm thinking sleep disorder breathing. I know I will likely treat. I don't do a test, the results of which I'm not going to do something about because it costs money. And so I think if your index of suspicion is high, you respond to that accordingly and then treat it. But pulmonary functions, I think, are important to follow patients. I will do the sleep study when I think I'm likely going to need to do another one with the pressure, and that's it. And then I'd maybe repeat it once in 3 to 4 years, maybe even later, because most I keep the cost in mind as well as time. I actually see another question that says, do I routinely score central hypopneas? And I say that for patients who have neuromuscular disease, yes, we do score them. And because this is unique to that particular pathology, and that's why I say the diagnosis or the interpretation of sleep studies needs to be in the context of the underlying diagnosis, always.
With increasing use of SMA drugs, what is your experience with respect to respiratory function and getting off NIV in those who are on nusinersen versus risdiplam versus Zolgensma?
So risdiplam is just starting over here. Nusinersen has not shown me anybody who could come off ventilator support right away. I don't have anybody who has started on it and come off vent support. No. We do know that SMA gets worse over time. Could be the second, the third decade for SMA 2 or 3. So therefore, I think these medications may see better benefit there because these patients remain relatively well.
Because the study which I was there in Australia when they started with nusinersen, the endpoint was the death of the child. That's what when they...
Yeah.
So now from SMA 1, it has come to SMA 2 and 3. So what do you think? Is it basically it's a...
I think it depends on when you start your treatment, what age. If you start a drug after there is significant thoracic deformity, there's no way this kid is going to come off ventilator support. It's not happening. So if someone has bad form, they're never going to have good function.
So difficulties in using NIV in kids and tracheostomy patients.
It's all style specific and what your goals are and what your goals what the goals of the family are. If the family says, this is an issue of ethics, right? There's no right or wrong decision here. Our first goal should be never to do harm. And that's not just to the child, but also to the family and the impact on the other children. And a lot depends on what expertise is available to the families as well. That's why, what happens in Bombay could be very different from what happens in, Sikkim or in Assam or even Eastern Europe for that matter. I've been to areas of Eastern Europe where I feel like Bombay is state of the art compared to some of those areas. So not every treatment is the right option in every situation. And I think it's more about personal style and comfort with handling and all of that and the family's ability to deal with it.
So are there any screening procedures or hints of early diagnosis in infants or neonates for your NM neuromuscular disorders?
That's a really good question. And so I pay a lot of attention to the mechanics of breathing, the respiratory paradox, the phase delay, the saturation instability, a baseline blood gas, just to look at ventilation, the ability to feed. If a child is not able to feed appropriately, I would say we definitely need to get a sleep study to understand how pathologic upper airway muscle tone is. And sometimes even to know whether a video swallow can help you ascertain the act of swallowing, is that normal or not, is really important. Because if you have a child who can't swallow, cannot handle oral secretions, you can't put somebody like that on face mask ventilation. They will aspirate their saliva and it'll just be a downward spiral. So the pathology will need to dictate your plan of action, and certainly the underlying diagnosis.
So we have seen using your ETCO2 and TCCO2s in your PSGs. Is it mandated to use both, or?
So I showed you an epoch where the end tidal was not reliable, but the transcutaneous was, and we use both. I would say if you ever have a neuromuscular patient, yes, my recommendation is absolutely should have capnometry. At least end tidal, if not transcutaneous. If you had to pick one, get transcutaneous. If you can do both, even better. But if you have to pick one, get the transcutaneous.
Because the Australia people uses only transcutaneous, I haven't seen end tidal, but it's too costly to purchase for a transcutaneous.
Yeah, but you know, the probes can be cleaned, can be reused, and you know, end tidals, you have to discard those. So that's, in that regard, I feel end tidal transcutaneous is a little better. Doesn't require that degree of recalibration that end tidals sometimes need.
So is there any role of early respiratory exercises in the early childhood, which plays in any important role in your improvement in the lung function?
So that's really a good question. And I have always been a proponent for maximizing chest wall excursion. And I do show families some manual maneuvers. Our physical therapist also does those. I try to focus more on diaphragmatic breathing so that there is greater degree of thoracic excursion. Sometimes I use an ambu bag and a mask just to give them those large deep breaths, just in order to keep the compliance of the chest wall healthy.
Now, does the music and Vedic chanting help in this way?
I don't know, but I take a very practical approach. If I'm asking somebody to do something manually, they're only going to be limited by the strength.
Correct.
So telling them to sing louder or longer is only going to exhaust them, is going to frustrate them. And so I think if you're going to do passive exercise, it's going to be better, like an ambu bag, because that is going to give you an immediate benefit. It's going to immediately improve lung compliance. And that we know from previous studies can be sustained for up to 4 hours, 2.5 to 3 hours after even 2 minutes of therapy.
Because one of the physicians told me that if you chant, your oropharyngeal muscles will improve, that they'll get toned up. I don't know. So
if you have intact normal muscle strength, yes.
okay.
Because we do know that aerobic exercises and running, all of that has improved upper airway tone of normal individuals to reduce the likelihood of sleep apnea. So that has been well studied. So to your point, singing, the chanting, especially that constant low tone, it requires very good coordination of the upper airway muscles.
Yeah.
That's not going to hurt at all.
So apart from your non-invasive intermittent positive pressure ventilation, what are the other methods available to delay the progression of muscle weakness, and what is the place of breathing exercises?
So I think we talked about breathing exercises.
Yes.
I'm not going to, if a disease is progressive, you can only exhaust it that much. Because, early breathing, passive breathing exercises helps reduce the inertia of the chest wall. And that is really where they burn calories. So there is help. There's some benefit in doing that.
Other than non-invasive positive pressure ventilation, any other methods for the delay of the progression?
I don't think so, because non-invasive positive pressure ventilation includes nasal mask as well as what we call SIP ventilation. And I don't know, Pawan, if you had seen some of my patients with the SIP ventilator when you had come.
Yes, I saw.
So I think that when you come to a point where you are offering your patient ventilator support, you are pretty much at that end of the road.
So do you follow the FE1 of less than 30% parameter in case of NFD to start a BiPAP, or wait till we do a PSG?
No, I usually start earlier. None of my patients have ever started BiPAP at 30%. At 30%, they've almost always been fully symptomatic. And so I've never waited that far.
Has the pandemic changed the attitude towards the acceptance of home cardiorespiratory polygraphies in the place of hospital-based
No.
PSG in children?
No. In fact, just for the record, home polysomnography is not yet approved for patients with medical complexities like neuromuscular diseases. But in general, not really.
Now, Omi Narayana, a sleep specialist and a pulmonologist from UK, has asked, would you give a tracheostomy to a child with SMA1 for a long-term ventilation?
Oh,
without New Synerson?
I would say it's dependent on the goals of the family and how affected the child is. If you're planning on doing nusinersen and you want the child to come off ventilatory support, and there is a severe amount of thoracic, anticipated thoracic dystrophy because of the dyskinesia of the thorax and the abdomen, I would be inclined to offer a tracheostomy ventilator, knowing that with treatment early enough, especially if it's a newborn, that they may hit a point where they may not need support in the day, but will only need it at night. But that's, again, only possible if you have a good chest wall shape, which I can say is really hard to get with non-invasive positive pressure ventilation. Part of it is also that with long-term non-invasive support, these patients develop craniofacial issues, and that itself increases upper airway resistance and makes it hard for them.
It's my question which I wanted to ask. So you said on recommend and a vertical thing. So what is your offering on your spinal deformity correction surgeries? Is there any role of your corrective surgeries at an earlier stage to make them to sit straight in your wheelchair or anything which helps you in the better development of the muscle or anything?
No. I think the positioning is important for comfort and to make sure that people are not going to get into trouble. So having the right positioning within the chair, the side supports, is important to keep them straight. It is a possibility that it may help to some extent, but I think it's more comfort that gets better. I think the issue, because I've seen supine patients also develop scoliosis. So I can't say that gravity plays havoc all the time, but I'm sure it does impact.
Sir, I can ask you a stormy question. Is sudden infant death syndrome an area of neuromuscular area, or is it neurological?
So that's a really good question. And the current data, so that was one of my initial research projects 20 years ago when I did that. But
I think I'm asking SIDS.
SIDS.
Yeah.
And so by definition, SIDS is a diagnosis you would give only if you have no other underlying known diagnoses underlying, because it's unexpected. So if you have an underlying neuromuscular diagnosis, it's not SIDS.
Correct.
It's probably respiratory failure or cardiorespiratory failure that occurred. But as a mechanism by itself, SIDS, they discuss this as multifactorial in origin, and most of this seems to be related to delayed hypoxic and hypercapnic responses at the brainstem level.
Brainstem.
It's a phenomenon of what we call autoresuscitation, in that normal mechanism is broken. Is
mostly insensitivity of the receptors to the drives, probably.
Yes.
Pawan, continue, please.
Sure. There are all questions have been answered.
Sir, it's actually wonderful feast for us, and we want to continue for longer. But you know, the attendees
my clinic has started.
You are drinking water, sips of water, and you know you are energizing your palatine muscles, your throat. So we should not cause you. Sir,
Not a problem.
sir,
I'm
please
happy.
send to my email ID. I will send it to you an article
Sure.
so that everybody would read. And we
Okay.
would again invite you for Respicon. Again, say, Pawan, I know. We will invite you again for Respicon in December. So please spare your a few minutes for us, and we will have some real mouth-watering session. At that time, sir, we will request you something about physiology. See, what I have in mind is physiology of breathing, which could be very useful for normal physiology, which will be very useful for many of our pediatricians because they need to understand physiology more. And I regret to tell you, sir, many of the times you must be recollecting your undergraduate days. We hardly teach basic sciences properly. But only when they go to post-graduation and super, they start looking at basic sciences. And I think even sleep, I don't recollect for being well studied in our MBBS days as well. I mean,
No, I agree with you because I think 20 years, 30 years ago, sleep was still very new to the field,
new to the
let
field.
alone pediatric sleep.
So somewhere I think, sir, after knowing all the applications, you should come back and teach here the basics for us. I'm going by the requirements. While I see the applications are done by handful of people in India, but majority of them, if they understand physiology, I think they will recognize and refer appropriately. So with these concluding words, so Pawan, with your permission, can we conclude?
Yes, sir. Yes, sir. I should thank Hemant for
Yeah,
giving
yeah.
us.
So that's what.
It's been.
Sir, thank you very much. I would request whoever is in the chat box, please type thank you. Thanks a lot for our Dr. Hemant for spending so much of time, energy, a smile, and the
I'm
simplicity
happy.
with which you have taught us, and it was very lucid. And I never knew that you can use a piece of paper for diaphragm and a syringe for the chest wall. And that you will see in my next module, sir. You should transfer the copyrights to us. So,
No,
so nice. So
Hemant,
nice.
there were participants from UK as well as Sri Lanka. So it
Oh, wow.
was, yeah, yeah. So I know because I've seen you talking of physiology when I was there to the patients because you had a combined clinic with the neurologist, cardiologist. When you see a DMD kids, it's an excellent thing which to look into. And I had a fantastic experience with you at that time. So thank you, Hemant, for accepting, and we look forward to you as many sessions as possible if you can.
Sure.
Thank
Sure.
you, sir.
Happy to have
Thank you.
been able to do this. And I thank you so much for hosting us over here. It was wonderful. It's just as wonderful for me. And I appreciate the opportunity.
Yeah, yeah. Thank you very much, sir. In fact, it was a pleasure for us to watch everything.
All of you, please be well, be safe, and take care of yourselves. Because if you don't take care of yourselves, you can't take care of other people.
So nice of you. And for the viewers, please continue to watch Respinars. You will have wonderful dinner time on every Monday. The week begins with academics. So thank you very much.
Thank you, Hemant.
Thank you, Pawan, for bringing our Dr. Hemant. Now he's our Hemant. He was your Hemant. Now he's our Hemant. I'm sorry, sir, for being talking to you so closely.
Happy to share. I'm happy to share.
So
Thank
we
you
will
for the
meet
opportunity.
again and again. And thank you Victor, Kadam, and Dr. Gauri Shankar. Many of you, Dr. Anthony Teres was there. I was trying to invite her, but I mean, it was difficult for me. So maybe my apologies if everybody couldn't get an opportunity. See you again next Monday on next Respinar. Keep watching the activities of the chapter. Whenever we post in WhatsApp group, please forward it to all so that there'll be maximum attendance. And thank you very much. Good night.
Thank you.
Good day,
Thank
sir.
you.
Good day.
And over to ClearNet because they have been wonderful sponsors. Sir, they have been helping us as backbone of our technology team. So they are really good. They're coordinating a lot. Thank you very much.
Thank you. Thank you. Bye-bye.
Janet, I would like to thank all of you. Good night.
Thank you. Good night.
Thank you. Bye.